Another great question here is on P53, co-alteration. And I'll take this one. We talked about KRAS and co-alteration. There's lots of discussion now, right, Dr. Preeshagul, about EGFR and co-alterations as well. And this is uniquely different from a compound mutation, right? What Dr. Preeshagul was just talking about are having two mutations driving the cancer. These are potentially, passenger alterations like P53, which may not be present in every single clone of the cancer, but may be present in a dominant clone of the cancer. And we know that the prognosis for patients who have co-alterations in P53 may not be as good as those who don't. So the question here is, how do you think about treatment of a patient with a P53 and an EGFR mutation? Well, we have great clinical trials in this setting. Dr. Helena Yu at MSK has a study open. We have it open at our site as well, where patients can get osimertinib, a third generation EGFR TKI. And if they're still shedding the clone 4 weeks out with plasma next generation sequencing, we then will add chemotherapy. But curious, Dr. Preeshagul, in the future, do you think we'll be doing more for this patient population, such as the FLORA chemotherapy plus the osimertinib, or maybe even, amivantamab, the EGFR and c-Met bispecific, plus lazertinib?
So I think the first thing is awareness and understanding that you need to look for TP53 and RB loss in patients that harbor EGFR alterations, because sometimes you might get your next generation sequencing report back and you might see EGFR exon 19 deletion and TP53, oncogene mutation, right? And then you might just think, oh, it's just, TP53, whatever. But that should send an alarm off in your head to ask your tissue to be sent for immunohistochemistry to see if you have loss of RB. Because if you have loss of your function of RB, then we know you are more at risk to develop what we call a resistance alteration of small cell transformation, where your non-small cell changes to small cell. So I fully believe in this study. Obviously, Dr. Helena Yu is one of my amazing colleagues and mentors, and yours as well, Dr. Sabari, I know. And I've enrolled many patients on this study to see if it makes a difference. I'm hoping that awareness is going to lead to change here, that we won't even need to have a clinical trial, that the second we see TP53 and EGFR, we will hunt for that RB and we will put these patients on OC plus something. I do feel a little bit more strongly about adding a small cell regimen in there somewhere. I'm concerned that if we just gave them AMI and lazertinib and OC, it may not hit that small cell clone. So I do think having, platinum etoposide in there to just pack a little bit more punch should be given. What are your thoughts?
It's important to note that we don't really have prospective data yet in this patient population. So I think getting osimertinib alone is never wrong. But I agree with you, if you're starting to see emergence of resistant clones, and so that's the difference between upfront treating and versus down the road resistance, I agree it's of concern. Now, when we talk a lot about P53 and RB1, what we're talking about are genes that suppress tumors. These are tumor suppressor genes and very difficult to target with targeted therapy, whereas EGFR is an oncogene, and that's something that we can actually block or inhibit. So I agree. I think we're going to need more data and better therapeutics, particularly for those patients who develop these high risk sort of, resistance pathways, and, very tough. I don't generally use, platinum and etoposide yet in patients who just have an RB and a P53 mutation or a loss, unless they have a true histologic transformation. It's interesting, preclinically, you do see some small RB1 clones, and we don't know if that's dominant in the tumor. So really a lot of unknowns here and a lot more investigation needed.